Hello everyone, this is Pharm review part 2. So autonomic nervous system, autonomic agent. Here you have nicotinic autonomic receptor. So it is in the ganglia, in the adrenal medulla, and neuromuscular junction, and central nervous system. So then the next one is the muscarinic acetylcholine receptor. You find organs innervated by the PNS, peripheral nervous system, the central nervous system, cortex, and hippocampus. Toxin that inhibit acetylcholine release, like botulinum toxin, Botox. Does the peripheral nervous system innervate vasculature? No. Acetylcholine decrease blood pressure, heart rate, bronchial dilation. So which means acetylcholine can lead to bronchial constriction. Acetylcholine increases salivation, lacrimation, GI secretion and motility, urination, meiosis. That's for pilocarpine, that's why you get meiosis. Methanochol is an muscarinic acetylcholine receptor agonist. And it is resistant to the hydrolysis of acetylcholine esterase, which break down acetylcholine. So that is used for methanochol used for urinary retention. Acetylcholine esterase inhibitor, you have neostigmine, which is the quaternary amine, etrophonium, which is the short-acting acetylcholine esterase used in tensilon tests. So if you have a patient with myasthenia gravis, you can use tensilon test or etrophonium injection and test for myasthenia gravis. Donepezil, this is a drug used in Alzheimer's. So in the Alzheimer, actually use acetylcholine esterase inhibitor to try to increase the level of acetylcholine. So Alzheimer's disease, you have donepezil, galantamine, rivastigmine, and taquine. So they all are acetylcholine esterase inhibitor. With one exception is memantine. Memantine also used in Alzheimer's disease. Memantine is actually a glutamate antagonist. Irreversible acetylcholine esterase inhibitor, you have ecothiopate and isoflurofate. Ecothiopate and isoflurofate were used actually for glaucoma treatment. Agent reactivate inhibited acetylcholine esterase, bralidoxim. So in this case, like for instance, if a patient get poisoned in terms of by organophosphate, like found in insecticides, so you want to reactivate acetylcholine esterase, you can use bralidoxim. Antidote for atropine overdose is actually use one of those acetylcholine esterase inhibitor. So like for instance, antidote to atropine would be physostigmine. Other drug class with antimuscarinic side effect is antihistamine, tricyclic antidepressant, and phenothiazine, like chlorpromazine. So these classes of drug are the drug that are not friendly to elderly in terms of side effects. So remember, antimuscarinic, antihistamine, tricyclic antidepressant, they can cross-react and overlap. Depolarizing neuromuscular blocker. So you have succinylcholine, that's the only one, remember, depolarizing in the sense that at first it will stimulate the contraction of the muscle, and then it will just stay on the receptor, and what happens is that it will lead to placid type of situation, and then you get paralysis. So first is depolarization, and then it stay long enough, you get twitching, and then placid, and then paralysis. So in this case, used for endotracheal intubation, using for electroconvulsive therapy, sometimes used for bipolar patient, or even sometimes in other mental disorder like schizophrenia. Malignant hypothermia can happen with succinylcholine, especially when you use it with halothane anesthetic type of gas, and the treatment for malignant hypothermia is dantrolene, which is a calcium kind of antagonist. Non-depolarizing neuromuscular blocker, so in this case the big molecule looks similar like acetylcholine, and it just works as an antagonist to the nicotinic receptor, nicotinic cholinergic receptor in the neuromuscular junction, tuberculin and atracurium. Two major neurotransmitters for sympathetic nervous system is epinephrine and norepinephrine, or adrenaline and noradrenaline. Amino acid precursor to dopamine, epinephrine, and norepinephrine is tyrosine. Enzyme metabolize norepinephrine. You can do it by monoamine oxidase inhibitor or monoamine oxidase, and the other one is catechol O-methyltransferase, so MAO and COMT. So MAO tend to be in the presynaptic terminal, whereas COMT usually found in the synapse or post-synaptic area. A type of adrenal tumor, pheochromocytoma. So the treatment in this case, you use phentolamine, which is just the adrenergic blocker. Because if you have pheochromocytoma, then the adrenal gland producing too much in terms of epinephrine, in terms of sympathetic stimulus, so you want to use a phentolamine, which is adrenergic blocker. Alpha-2 agonists, presynaptic, like clonidine, guanfacine. So clonidine, in terms of usage, it can act as an agonist in the presynaptic receptor. When it is working on presynaptic receptor, the effect is that it will have negative feedback and inhibit the release of norepinephrine. So in a sense, it is an antagonist. So it will work on presynaptic terminal, it work by inhibit the release of neurotransmitter. But if it works in postsynaptic receptor, it actually may act as a pure agonist in the alpha-2 receptor. Alpha-1 agonist, you have phenylephrine, which we use for dilation, and that work on the dilator muscle, and also it can actually work on the alpha-1 in the blood vessel to constrict the blood vessel, and that help in terms of nasal congestion. Also, you can also use in the eye in terms of vasoconstriction to differentiate between scleritis and episcleritis. So episcleritis will blanch and scleritis will not. Type 1 hypersensitivity reaction can be treated by epinephrine, right? That's why there's EpiPen in emergency kit. Tyramine is a compound related to norepinephrine, and can be found in food like in cheese, in wine, in fish, chocolate, processed meat, sauerkraut. So the key to tyramine is that if a patient on monoamine oxidase inhibitor for depression, they should be educated about possible food interaction, because if monoamine oxidase inhibitor is taken and then you have this food with high level of tyramine, it interact and it may lead to too much of sympathetic stimulation, and you may get a hypertensive crisis. Alpha 1 antagonist, prazosin, doxazosin, tamsulosin. So in this case, the alpha 1 blocker, osin, and it's used for high blood pressure and benign prostatic hyperplasia. I think the only thing to remember for eye care is that tamsulosin or Flomax can actually lead to floppy iris syndrome. So floppy iris syndrome, so patient on this medication may be taken out before they go for cataract surgery. Beta blocker, you have propranolol, timolol. Those are the non-specific beta blocker. And then if you have a patient who have asthma, then you want to use a beta 1 selective antagonist like betaxolol, metoprolol. So they are more cardioselective because they work on beta 1. Beta 2 is in the lung. Alpha 1 and beta blocker. So this is an alpha 1 blocker plus a beta blocker, labetalol. Non-cardiovascular use of propranolol, you can do into stage fright to calm you down, or another thing is prophylaxis of migraine, prevention of migraine. Taper beta blocker, usually when patients on beta blocker, you want to taper them slowly down because of the upregulation of beta receptor. If you're going to take the patient off abruptly, the patient may have tachycardia, hypertension, and can lead to death. Pheochromocytoma. So I mentioned already we use phentolamine. Metirocin can also be used. That basically just inhibit the production of norepinephrine, so then you have less of norepinephrine around the body. Okay, so this example here is just a summary of some of the drugs that work in terms of antibiotic drug in terms of the mechanism of action, and just pause and then look at it, just review in terms of mechanism of action of different antibiotics. So here's another slide. You can pause later on just review too, just in terms of what the different antibiotic that can cause toxicity, especially in young children. So an example would aminoglycoside can lead to ototoxicity. We learned already in terms of 8 nerve damage. Chloramphenicol is a great baby syndrome because baby doesn't have enzyme to metabolize the drug. So sulfonamide, we say connectorus because it displays bilirubin, and tetracycline you already know because of bone growth, inhibition of bone growth, and dental staining. Okay, CNS agent, systemic anesthetic. So usually when anesthesia, you have 4 stages. You have analgesia, excitement, anesthesia, medullary depression, and usually the time is that you go from analgesia to anesthesia, and then you try to avoid excitement, and then definitely want to avoid medullary depression, because if you have medullary depression, you will have no breathing. Minimal alveolar concentration is important in terms of potency for anesthesia. Nitrous oxide have a large minimal alveolar concentration. Halothane have the smallest, but then remember halothane are prone to malignant hypothermia, so it is not being used that often anymore. Now you can tend to be used more of the IV anesthetic like propofol, fentanyl, ketamine. So propofol is a very good anesthetic, but it's a weak analgesia. So propofol is good for induction when you start, and then after you do the induction, then you can use actually the halothane gaseous type of anesthetic like sulfofluorine. That would be the new version in terms of maintenance of the anesthesia. Local anesthetic, proparacaine, the ester compound, lidocaine, and more amide compound. And usually in clinic, most of the local anesthetic are the ester type, even though the ester type tend to have more frequency of leading to allergy reaction. But then because they're ester, they are more prone to esterases that we have in our body. So ester base tend to be shorter in duration of action. Whereas lidocaine is an amide. Amide is metabolized by the liver. Amide tend to have a longer duration of action. So usually in clinic it's ester base, but if you have a patient who is allergic to ester, then you may need to use a lidocaine base. Medication combination with anesthetic, usually you have epinephrine combined in a very diluted amount to help to constrict the vessel, to help to keep the anesthesia longer locally. Mechanism of anesthetic mainly work through a sodium channel. Example would be a lidocaine. And another possible theory is that anesthetic may be just working similar to alcohol, like volume expansion of the cell membrane, and then just numbing the cell membrane, reduce excitability. Anesthetic with vasoconstriction, the only one, remember, cocaine is the one that it has the vasoconstriction effect, so it does not need like the dilution of epinephrine to help. Allergic reaction associated with ester and or amide, I mentioned already, usually ester molecule. Opioid, so endogenous opioid, you have endorphin, dynorphin, and enkephalin. Prototype of opioid, you have morphine. Opioid analgesic, morphine, and meperidine. So what happens is that it can work on muscarinic acetylcholine receptor and lead to meiosis. So if morphine overdose, you tend to have more of a meiosis problem. Cough suppressant, codeine is best in terms of suppressing the cough center, but out there dextromethorphan is used because it doesn't get as much into the brain and less of that addictive type of problem. Opioid overdose, respiratory depression, and I said meiosis already. Antidote for opioid overdose, you have the naloxone, which is the mu-opioid antagonist. Combo with codeine, you have acetaminophen, which is Tylenol, and codeine. It could be Tylenol 3, Tylenol 4. Partial opioid agonist, buprenorphine and pentazocine. So these are partial opioid agonists. So remember, partial agonists can also act as antagonists. Remember that it just depends on how abundant is the partial agonist in relation to the full agonist. So for instance, if you have more of buprenorphine, then you have morphine in the body system, then the effect would be that the buprenorphine, which is a partial agonist, will act as an antagonist to antagonize the full effect of morphine. Traumatic brain injury and opioid. So that usually opioid are not used in traumatic brain injury because opioid can increase intracranial pressure. Opioid for diarrhea, in this case, you have loperamide diphennoxylate. So these are a derivative of opioid, but they are bulky and they do not get into the brain, so that's why they just work outside in the peripheral system to help to prevent diarrhea. So it can slow down the GI motility and help to prevent diarrhea. Non-opioid analgesic, this is tramadol or Ultram. So this works slightly differently because they are not the typical opioid, and they can work on the central nervous system in terms of the other neurotransmitter, or maybe bind to also block the opioid system. Anxiolytic and sedative hypnotic, you have non-benzo sleep aid. Remember, in this case, when sleep aid, they tend to have the Z in the compound, so you have Z, zolpidem, zaloplan. Benzodiazepine usually have PAM, LAM, right? Diazepam, prazolam, and benzodiazepine application used in muscle relaxant, can be used in terms of anticonvulsant, anti-anxiety, sedative hypnotic. Prototype of benzodiazepine is chlordiazepoxide. Benzodiazepine withdrawal can have insomnia, anxiety, agitation, seizures. Potential fatal combo is barbiturate and alcohol, or even benzodiazepine and alcohol, because both are seen as depressant. Long-acting barbiturate is phenobarbital. Barbiturate indication is for seizure, so anti-epilepsy. To prevent barbiturate withdrawal, you can use diazepam, which is a benzodiazepine. A sedating antihistamine, in this case diphenhydramine or Benadryl. So the first generation H1 blocker can get into the brain relatively easily and can cause sedation, whereas the second generation, like the Claritin, Clarinex, they actually are quaternary amine and they cannot get into the brain as much, so that's why you have less of a sedating effect, and that's why the marketing approaches say that non-sedating. Antidepressant, non-selective monoamine oxidase inhibitor, you have phenelzine. Monoamine oxidase type B inhibitor, sertraline, and which is used in Parkinson's disease. Usually, in terms of drug interaction, its monoamine oxidase inhibitor should not be combined with selective serotonin receptor reuptake inhibitor, SSRI, for antidepressant, mepyridine opioids, because they can lead to serotonin syndrome. This is a syndrome that can lead to rigidity, diaphoresis, hypothermia, and seizures. Tricyclic antidepressant mechanism is inhibit reuptake of serotonin and norepinephrine. Example of tricyclic antidepressant, amitriptyline, imipramine. So usually the SSRI, the first class, will be used for as antidepressant, but if a patient not responding to SSRI, then tricyclic antidepressant can be tried and used. Tricyclic antidepressant tend to have a lot of side effects because it can cross-react, as we said, with anticholinergic, antihistamine type of effect. And remember, in terms of antidepressant treatment, usually a patient needs to allow for a few weeks for the drug to be taking effect. The 3C for tricyclic antidepressant toxicity, remember, it can lead to cardiotoxicity, convulsion, coma. Example of SSRI, you have fluoxetine, which is Prozac, and paroxetine, which is Paxil, and sertraline is more of a Zoloft. SSRI side effect, and organismia. So in this case, it's a sexual dysfunction, agitation, anxiety, and the sexual dysfunction is the one that tend to lead to non-compliance. SSRI, other indication can be used for bulimia, OCD, panic disorder. SSRI and P450. SSRI can inhibit cytochrome P450. Antipsychotic drug. Positive symptom, hallucination, delusion. A negative symptom is flat affect, amotivation, social withdrawal. Typical antipsychotic mechanism usually work on dopamine type 2 receptor, chlorpromazine, thyroidazine. So those are the phenothiazine type of drug. Remember, phenothiazine can cause retinal toxicity, can have deposition in the lens or in the cornea. A typical antipsychotic mechanism usually work on serotonin and dopamine type 2. Example, risperidone, aripiprazole, or Alibify, that's the brand name, clozapine. Phenothiazine, chlorpromazine, thyroidazine, and I already mentioned phenothiazine and retinal toxicity. Extrapyramidal symptom. So usually when you block the dopamine receptor, it may lead to extrapyramidal symptom like dystonia, rigidity, trauma, bradykinesia. So almost like a drug-induced Parkinson type of effect. Medication to treat extrapyramidal syndrome. You can use benztropine, which is a muscarinic antagonist, and amantadine. We said that it's influenza drug, but it's used in Parkinson. Antipsychotic prevent emesis. So antipsychotic can be used because it can work on the chemo trigger zone, the dopamine receptor in the chemo trigger zone in medulla. Antipsychotic for negative symptom, risperidone, atypical kind. When we say atypical, because it work on both dopamine and serotonin receptor. Intractable hiccup, you can also use chlorpromazine. Potential life-threatening side effect of antipsychotic is neuroleptic malignant syndrome, similar like what we said about serotonin syndrome. This is neuroleptic because due to antipsychotic malignant syndrome, hypothermia, rigidity, outer mentality, cardio instability, and this can lead to death. Neuroleptic malignant syndrome treatment, you can use dantrolene and bromocriptine. Dantrolene, we said it was antidote for malignant hypothermia, and bromocriptine is a dopamine agonist. Parkinson symptom, bradykinesia, muscular rigidity, trauma, postural instability. Dopamine subtype in Parkinson's disease, you have D2, work through the GI system, decrease cyclic AMP. The neurotransmitter imbalance would be too little dopamine and too much acetylcholine. So antimuscarinic agent can help to reduce the acetylcholine imbalance by benztropine, trihexylphenadiol, the amantadine, anti-influenza A, monoamine oxidase B inhibitor, selegiline, dopamine agonist, bromocriptine, pergolide. Bromocriptine indication can also be used in prolactin anemia because dopamine actually a natural inhibitor of prolactin, one of the posterior pituitary, one of anterior pituitary hormone, prolactin. Bromocriptine we saw already with dantrolene in treatment of neuroleptic malignant syndrome, and bromocriptine can actually use in acromegaly as well. Bromocriptine side effect, headache, dizzy, hypotension, hallucination. So hallucination is a good point to remember in terms of Parkinson's patient when they use dopamine drug to treat. For Parkinson, they can get hallucination and can get confusion. Catechol O-methyltransferase 1, tocapone and entacapone inhibitor. The catechol or methyltransferase inhibitor. Because of dopamine, the L-DOPA will get into the brain, converted to dopamine. Usually dopamine is too bulky to get into the brain, so that's why you need to use the precursor first. Anticonvulsant, you have partial chronic tonic, and you can use phenobarbital, phenytoin, carbamazepine, valproate. Phenytoin can lead to gingival hyperplasia, also with the calcium blocker here, nifedipine and cyclosporin A. Manic depression, you have lithium, carbamazepine, valproate, benzodiazepine, gabapentin, topiramate can be used for bipolar patient. So remember, Topamax, topiramate is also an anticonvulsant drug. Topiramate, the only thing that you can remember is that it may lead to bilateral angle closure because it leads to swelling of cellular body in both eyes. Diabetes insipidus, because if you use lithium, one of the side effects is that it can lead to too much urination, diabetes insipidus, and in this case you can use antidiuretic type of hormone to help use the thiazide diuretic amiloride. Okay, we'll continue next one on migraine.